Assalamualaikum, a very good day. Today we're going to explain about the understanding abdominal anatomy through case study of portal hypertension. The objective of this video is to explain the key abdominal anatomical structure involved in portal hypertension, to demonstrate how normal anatomy of the liver and portal venous system become altered in disease, to use a cirrhosis-related case study to illustrate the causes, anatomical changes, and the consequences of portal hypertension, and to help viewers understand how these anatomical changes affect radiographic appearance in clinical practice. What is abdominal cavity? Abdominal cavity is the largest hollow space in the body which is located between the diaphragm and the pelvic rim. It contains the major organs which is liver, stomach, small and large intestine, spleen, pancreas and gallbladder. The cavity is lined with the peritoneum, which is a thin serous membrane that protects organs and reduces friction. Blood supply and venous drainage are highly interconnected, especially through the portal venous system, which is essential for understanding portal hypertension. Function of the abdominal cavity is to house the protective digestive organ, allow movement and expansion of organ during digestion, and provide pathway for major vessels, including the aorta, IVC, and portal vein.
Next is the anatomy of liver. So this is the liver. The weight is about 1.36 kg located in the right upper quadrant. It has 4 lobes. Anteriorly, we can see right lobe and left lobe that's separated by falciform ligament. Posteriorly, we can see left lobe, right lobe, caudate lobe and quadrate lobe. Caudate lobe and quadrate lobe are separated by porta hepatitis, which contain hepatic portal vein, hepatic artery proper, and also common bile duct. The liver segmentation, according to the Quino classification, liver divided into 8 segments, S1 until S8, based on vascular supply and drainage. Firstly, S1, which is the caudate lobe located at the back of liver. S2 until S4 is formed up the left lobe. S4 is divided into 2 subsegments, which is 4A at the superior and 4B at the inferior. S5 until S8 form up the right lobe.
Next is the portal venous system. Portal vein originated just posterior to the neck of pancreas and anterior to the inferior vena cava. Function is to transport blood from the several organs in the abdomen to the liver, and the liver is responsible to filter and process the blood before it returns to the heart and circulates throughout the body. Portal vein has several veins that drain into it. Firstly is superior mesenteric vein that drains several organs in the middle of your belly, including your small intestine. Splenic vein that drains to the spleen. Inferior mesenteric vein drain to the portion of large intestine. Gastric vein drain to stomach, and cystic vein drain to gallbladder. Associated abdominal organ, firstly is spleen located at the lower upper quadrant at the tail of pancreas. It is part of lymphatic system. The function is to store blood, filter blood and fight infection. Second is pancreas, oblong-shaped organ positioned at the level of transpyloric plane. It has 5 parts. It is responsible in digestion and glucose control. The next organ is stomach, which is a J-shaped structure and located more to the left between esophagus and duodenum. It has 4 divisions, which is cardia, fundus, body and pylorus. And also it has 2 curvature, which is lesser curvature and greater curvature. Next is small intestine, about 6 meters long, consists of 3 parts, duodenum, jejunum and ileum. It is a major site of digestion and absorption of food. Lastly is the large intestine, which consists of cecum, colon, rectum and anal canal. Cecum is the proximal end of large intestine, where it joins with the small intestine at the ileocecal junction. Colon consists of 4 parts, which is ascending, transverse, descending and sigmoid colon. Rectum composed of small muscle begin at the termination of sigmoid colon and end at the anal canal. Anal canal is an opening to the exterior, which is the anus. Moreover, the major vascular structure in the abdomen is inferior vena cava, IVC and hepatic artery. IVC started at the cavogators of the diaphragm, which is level T8 and terminate at level L5. Located slightly to the right, the major vein that drain to the IVC is lumbar vein, renal vein, right quadrant vein, suprarenal vein, inferior phrenic vein and hepatic vein. IVC has thin wall and bigger lumen, which bring low velocity and low pressure of blood. Next is hepatic artery, which is the major blood vessel that supply the liver, stomach, pancreas and duodenum with oxygenated blood.
So now we will present about a case of cirrhosis-related portal hypertension with ectopic pulmonary hilar varices. So we have 6 underlying causes. First, portal hypertension is a major complication of liver cirrhosis. It usually causes varices in the esophagus or stomach, but rarely, varices can appear in unusual ectopic locations like the pulmonary hilum. Recognizing these varices is crucial because they can cause non-gastrointestinal symptoms and serious complications. So, about the patient information, the patient is a 40-year-old man with a 10-year history of decompensated cirrhosis due to chronic hepatitis B. He initially presented with repeated vomiting of blood and black stools, treated multiple times and endoscopic perusal ligation. Later, he developed a shortness of breath. Next, for the diagnostic findings, chest CT revealed enlarged vessel in the pulmonary hilum. Portography confirmed that ectopic systemic collaterals in both pulmonary hilum. Gastroscopy showed that persistent esophageal and gastric varices.
For the management, he underwent a transjugular intrahepatic portosystematic shunt (TIPS) procedure combined with embolization of the gastric coronary vein. This approach relieved his respiratory system and reduced the size of both ectopic and gastrointestinal varices. For the outcome, follow-up imaging showed marked reduction in pulmonary hilar varices. Overall, the multidisciplinary intervention was successful. The key point of this case study is number 1, cirrhosis-related portal hypertension can cause rare ectopic varices. Number 2, ectopic varices may present in non-GI symptoms such as shortness of breath. Number 3, effective management may require interventional procedure like TIPS and embolization in addition to endoscopy. All clinicians should be aware of atypical varices in cirrhosis-related portal hypertension. Early recognition and appropriate intervention can prevent serious complications.
Now we are going to talk about how portal hypertension affects the radiographic interpretation, patient safety and clinical consideration, selection of imaging modalities such as ultrasound, Doppler ultrasound, CT scan or MRI, and key anatomical landmarks radiographers must identify. For radiographic interpretation, dilated portal vein and collaterals. The enlargement of portal veins, which is greater than 13 mm, and enlargement of the splenic vein, and the presence of collateral vessels, such as paraumbilical vein, are important indicators of dilation. For varices, esophageal, gastric, and rectal varices may appear as serpiginous enhancing structures on CT scan or MRI. For splenomegaly and ascites, these are common secondary findings that must be recognized to avoid misinterpretation. For patient safety and clinical considerations, risk of variceal bleeding, radiographers must avoid invasive procedures because fragile collaterals easily ruptures. Contrast use caution. Patients with advanced cirrhosis will often experience kidney dysfunction. Evaluation of contrast imaging should be carefully assessed. Lastly, positioning and monitoring. Patient tolerance during imaging can be affected due to ascites and encephalopathy. Selection of imaging modality. Ultrasound detects the splenomegaly, ascites and portal vein. It is the primary non-invasive method. CT scan is highly effective for mapping collateral, varices and liver morphology. It is valuable for surgical planning. Doppler ultrasound will evaluate the direction of the blood flow toward or away from the liver, the speed and also the presence of the blood clots. MRI will provide better soft tissue contrast, using the MR angiography to visualize the portal venous system to avoid radiation. Key anatomical landmarks for radiographers. Portal vein confluence at junction of superior mesenteric vein SMV and also splenic vein. Hepatic hilum. Portal vein branches enter the liver. It is essential for evaluating blood flow within the liver. For collateral pathways, these including the paraumbilical vein, gastroesophageal junction, and retroperitoneal collaterals. Lastly, the spleen and ascitic fluid spaces. It should be detected to help assessment of clinical severity.